anti-inflammatory steroid, and as far as rejection goes, it causes emigration of the circulating T cells from intravascular tissue compartment to the lymphoid tissue, which inhibits production of T cell lymphokines that are needed to amplify macrophage and lymphocytic response. Basically, there are two culprits that are high in the rejection cascade. They're the T lymphocytes and the B lymphocytes. There's also other cells that are involved as well, but the T lymphocytes and the B lymphocytes are the ones that we target the most and try and get rid of them. Well, not get rid of them, but just make them not so smart. Prednisone has a huge slew of side effects: fluid retention, mood swings, increase in appetite. They get fatty deposits in their face, abdomen, and upper back, which is why they get those balloon faces or the Cushing-like face. They get oily skin, which they can have increased acne with. They get calcium loss, which increases their risk for osteoporosis, and they can also get GI disturbance. Another reason for Prilosec or Prilosec. You want to administer with antacids until their minimum dose is obtained. Kids will be on Prevacet or Zantac or something until we see how they do. So they'll be on it when they're first transplanted, and then we can make adjustments once the kids go home, once we see how their bellies are going to react. We want to watch for GI disturbances, especially bleeding. We start them out on a maintenance dose. First of all, they get a huge slug of steroid in the OR. They get 30 milligrams per kilogram, and that is their initial immunosuppression. And then after that, they're on it twice a day. And then we taper it down to a dose of 0.5 milligrams per kilo per day. I'm confused.
30 milligrams per kilo, you said?
Yeah.
That's the first dose?
Yeah. Huge. Then they're on they're on 1 milligram per kilogram twice a day, and then it tapers down to 0.5 milligrams, and then it per kilo per day, and then it tapers down even more to 0.1 milligram per kilo per day. And then we like to get the kids off of steroids completely by the time they're 3 to 6 months out from transplant, but all that's based on their biopsy history. Sirolimus is a medication that we have not used during the first year post-transplant unless we're forced to. But it is an mTOR inhibitor that you'll see some of the kids on when they're farther out from transplant. We use sirolimus as a coronary artery protector and also a kidney protector. And it's got good rejection coverage. Side effects of sirolimus are leukopenia, thrombocytopenia, hyperlipidemia. They can get effusions, they can get peripheral edema, they can get acne, they can get a funky lung, like a pneumonia, oligospermia, impotence, all that's possible. So we talk about this with the kids before we start it. We've seen several of the side effects. I would say probably a quarter to a third of the kids that we've put on sirolimus, we've had to take them off because they can't tolerate the side effects. It's once daily dosing, which is nice, and their dosing is based on trough levels as well. Other medications that the kids are on post-transplant, like immediate post, would be ACE inhibition or calcium channel blockade for blood pressure, diuretics, stomach protectors, nystatin. Because the kids are so immunosuppressed and they're at risk for opportunistic infections, especially like fungal in Canada, they'll be on nystatin 4 times a day. Your GI tract, which we all know is just a big long tube, if they get an infection in their mouth, it can travel the entire length of their tube because they're immunosuppressed, and it's really painful and it's really hard to treat. That's why the kids are on the nystatin 4 times a day for 3 months. CMV prophylaxis depends on the donor-recipient status, and this is why it's important to get those labs before their transplant surgery, because we've tested the kids before. It should be within 6 months of their last blood test for CMV, which is cytomegalovirus. The reason we get a little crazy about CMV is that if you develop CMV disease after you receive your organ, then that can facilitate the process of the coronary artery disease. Transplant coronary artery disease is the limiting factor to the lifespan of the organ itself. Your coronary arteries are the arteries that feed your heart muscle itself. If this is your heart and these are your arteries. And as you know or don't know, your coronary arteries come off the aorta and they just feed the heart muscle, the blood itself. They are in two major branches, the right and the left. And then they branch off and branch off and branch off. So it's sort of like a tree, and the branches get smaller and smaller, but they infiltrate the heart. And so where the disease starts most of the time is in the intimal, the distal perforators is what we call them, and you can't go in and fix those. So you're losing blood, your heart can become ischemic, and then you have symptoms of heart failure and all that again. So we look for that. We think it starts down there, but you can also get it in the bigger parts of the vessels. Sometimes you can stent it, sometimes you can't. But that's why it's really important for the kids to take their medication. It's important for us for them to exercise. It's important for us that they eat well. It's important for us that we put them on the right medications to help protect those for as long as we can. When I first started, we were giving people estimates of lifespan of the primary organ of being 12 to 15 years. Now, infants who receive organs are, their organs are lasting up to 20 years and doing really well. Other kids are going up to 15 years, so we're getting better at it, but we still have a long way to go because everybody's going to need another transplant. If nothing else happens, they'll need another transplant. Any questions about that? The protocols are on Otis if you want to look up more specifics. Rejection is our process where the body recognizes and eliminates non-self antigens. So cellular rejection is the most common type, and we think the biggest culprit is those T lymphocytes. That form of rejection, there's a grading scale, and depending on what grade it is, we will treat it or not. To treat rejection, we'd give them 3 days of high-dose steroids. We'd give them thymoglobulin if there was decrease in heart function. It can begin within the first 7 to 10 days, which is why we do biopsies within the first 7 to 10 days. Signs and symptoms of rejection, it can look like heart failure, it can look like the flu, it can look like a lot of things. If you look at these, they have temperature, they can or cannot have a temperature. Flu-like symptoms, they can have an increase in their heart rate or their rhythm can get kind of funky. They can start having fluid retention, changes in their blood pressure, and shortness of breath. Diagnosis, the gold standard is by a biopsy, and that's a cath procedure where they do a right heart cath with a biopsy. So they put in something called a bioptome. It's either through their groin or through their neck. You put a catheter in, and then you insert something called a bioptome. And the way I think of it is, you know those games in like diners where they have the claw and it grabs a toy? That's basically what it is. It looks like that, and it goes in and it's teeny tiny. It's not that big at all. And it goes in. The cath physician will take 4 teeny tiny pieces, and we can check for both cellular and vascular rejection. Here's a picture. And you can see down at the very bottom where in the ventricular septum. The reason that we need echoes afterwards is because it's taking teeny tiny pieces, and sometimes those teeny tiny pieces can turn into big pieces, which can turn into holes. So that's why they need to have an echo done after the biopsies. So if you have a kid who leaves the floor, and 11 West is the biggest floor that this happens from, as nursing, make sure that they have an echo scheduled for after the biopsy. If they don't, nag. They don't have a biopsy or an echo scheduled, or talk to the fellow or the resident and let them know. I think that they need to have an echo done to check for complications.
So where do they actually show?
So they go into the right ventricle, so they go through the right atrium, go through the tricuspid valve, and then into the right ventricle, and basically wherever it lands. So this is the biopsy grading scale. The grading scale that has the R after it is revised. We still talk about both grading scales though, which is why I put both grading scales here. Denervation tips for nursing. I had talked about before, higher heart rates than normal controls, meaning their heart rate resting will be between 100 and 120. Carotid massage doesn't change the heart rate. Atropine will not work because they're denervated. And then they'll have an absence of reflexive tachycardia, so that's when I'm talking about when they go from laying to sitting or sitting to standing. It's usually for the older kids because they know their hearts differently. Little kids, they don't even notice it, they'll just accommodate to it. But older kids, you can have syncopal episodes with the older kids if they get up too fast because their hearts, the brain cannot tell their heart to stop pumping fast enough. It has to wait, like I said, for those catecholamines for the back roads. And then orthostatic hypotension. Immunizations post-heart transplant. Responses to vaccines are less vigorous in patients who are immunosuppressed. Live virus vaccines like MMR, we don't give oral polio anymore, but sometimes if we have kids from foreign countries, they still have oral polio. And varicella or chickenpox should not be given. The reason is that because they're live virus vaccines, there's a risk that they can develop that disease itself. All other vaccines may be given after 3 to 6 months post-transplant. They should all be getting the flu shot, not the flu mist, because the flu mist is live virus. And then Pneumovax is okay. However, most of the time when the kids come in here, they're sick, so you don't want to give them a vaccine when they're sick, depending on what it is. And the vaccine should not be given for 3 months after a rejection episode for the same reasons. Infectious complications. During the first 6 months, we're more concerned about bacterial infections than we are late. And then as time goes on, we're more worried about viral infections. And then the opportunistic like fungus and PCP are during the first 3 months. So you'll also find, besides the nystatin, you'll find that we're putting kids on Bactrim more and more. However, we've had nothing, well, sometimes we don't have problems with it, but we've had a lot of trouble with leukopenia with kids who are on Bactrim. So depending on who you talk to in the transplant team, will we say sure or no?
Yeah.
Late complications of heart transplant, we talked about that, transplant coronary artery disease. Some people think that it's a form of chronic rejection, but there's different ideas. Nobody really knows why this happens, and so whoever does figure it out for sure will be golden. Because then we can fix it, or at least we can start to try to fix it. It's progressive intimal and medial smooth muscle proliferation within the allograft vascular walls, secondary to immunologic and constitutional factors resulting in loss of coronary flow reserve and eventual luminal obliteration. It's what I said before. They eventually failed and the blood can't get through them because of the changes in the vessel walls. Any questions about that? Or do I still have all of you? I know it's a lot of information. Transplant vasculopathy, the incidence in pediatrics is 10 to 50% of children, and that's because something else usually happens to them. Symptoms, syncope, sudden death. There's no angina because they're denervated. Some kids who are farther out from transplant, like our person downstairs, can have, their nerves can grow back, so then they can have the shoulder pain, the arm pain, the shortness of breath, all of that. But sometimes people don't have any symptoms at all, and the next thing you know that we're getting a phone call, and unfortunately that person has died. Ischemic time can affect when this starts to occur, the number of rejection episodes or the expression of those PRA, the donor-specific antibodies, can affect when it occurs. Infections can affect it. Medications can affect it. Abnormal lipid panels or profiles can affect it. You can see it starting to occur if there's new conduction abnormalities like SVT. Echoes, if we can look at wall motion abnormalities. We don't do the dobutamine stress scans on the pediatric side, nor do we do IBIS on the pediatric side. But if there's an older adolescent, and we're that concerned about it, and they have kidney issues, then we may have them go to the adult side and have these more further testing done. CellSect can help protect the coronary arteries. Statins can help protect it. Sirolimus can help protect them, but the best form of protection is to get rid of them and retransplant them. We start doing coronary angiograms when the kids are 1 year out from transplant, and then we do it every 2 years until they're 5 or 6 years out from transplant when we think it has more chance of occurring. And so then we'll start doing that once a year, and we'll look at them. We have been doing some research on it. This is one of the studies that has been done. One of the other long-term risks to transplant is this post-transplant lymphoproliferative disease, or PTLD. They're the precancerous cell transformations that can lead to cancer, which needs treatment. It typically occurs 8 to 18 months post-transplant, and it's actually 3 to 10% of all solid organ transplants, and in our population it's about 5 to 10% of our total population. And the virus, like CMV, helps facilitate that process of transplant vasculopathy. EBV, or Epstein-Barr virus, can facilitate that process in a transplant population. Why PTLD occurs, we don't really know for sure. We think part of it could be due to the EBV virus, and we think also it could be due to over-immunosuppression. This just goes to the lifespan of organs, which we talked about a little bit before. Conclusions. Survival has improved dramatically over the last decade with improved immunosuppressive regimens. There continues to be a critical donor shortage, particularly for infants, with an overall 20 to 30% mortality rate while awaiting transplant. We have been utilizing some innovative strategies such as ABO-incompatible transplants and pre-transplant antibody removal, and those have all been designed to increase the donor pool and decrease mortality. And my little arrows didn't show up.
They're down the next row.
Oh! The long-term survivors usually have excellent, this is the most important part, is that long-term survivors usually have excellent quality of life, and there are no activity restrictions on these kids at all, except to be smart and use your head.